Schultz. I'm your host, Dr. David Bertone. This is our second show done via Zoom since the COVID pandemic. We can't be in the studio. So my guest is via Zoom, and we're going to talk about TMJ, or temporal mandibular joint pain, or what's commonly referred to as jaw or craniofacial or any kind of facial pain that might be emanating from the jaw. Our guest today is Dr. Michele Schultz-Robins. Dr. Schultz-Robins is a dentist at Two River Family Dental Center in Red Bank, and she specializes in TMJ disorders and oral facial pain. And she's been kind enough to join us today and talk about TMJ disorders. Dr. Schultz-Robins, thanks for joining us.
Thank you for having me today. So as you know, I'm Dr. Michele Schultz-Robins, and I practice in Red Bank, and I also hold a clinical assistant professorship up at Rutgers School of Dental Medicine, and I'm also on staff at Monmouth Medical Center in Long Branch, New Jersey. I am a member of the American Academy of Oral Facial Pain, where I sit on the executive board, and I also chair the Ethics and Grievance Committee and the Constitution and Bylaws Committee.
Cool. So how did you get involved with TMJ and oral facial pain as a specialty in dentistry?
Well, when I got out of dental school, it's a lot of filling and drilling, and that's interesting. But I wanted to expand my mind and really treat the patient more, more than just a tooth. I want to know, why is their jaw not opening properly? Why do they have clicking? Why are they getting headaches? And so I took a 2-year fellowship course at that point, it was University of Medicine and Dentistry of New Jersey. And I got my certificate in, well, it's now a fellowship in orofacial pain and temporomandibular disorders. And then I just stayed active and started treating patients.
Wonderful. So give us a little basic background. Actually, what is TMJ? So what does it stand for? And then what are some of the common signs? And I'll throw up a sign once you start talking about it.
Okay, so TMJ is your temporomandibular joint complex. And what it is, it's your jaw joint, which is your condyle that opens and closes when you open and close your mouth. And then it is your skull. And then as you can see, there's a little disc in between the condyle. Yep, there you go. The fibrous cartilage right there. Yep, little disc right there. And that is the articular disc, and that helps the condyle open and close, because the TMJ is an interesting piece of equipment we have. It's a sliding hinge. It rotates and it translates. So you can open and close, but you can also go side to side with it. So it will open and close, and then you open more and your jaw will go down and forward. And then again, side to side.
Okay. And so the problems come in when something happens at this joint level?
Yes, well, both. If something happens at the joint level, so the disc can be displaced, or the muscles associated with the jaw joint get inflamed.
Okay.
And that's when we have the problem. And the trick is to figure out which is really the problem. Is it muscular, or is it pure joint, or is it a bit of both?
Okay. I'm going to show another picture. And so this one might, let's pull up another photo here. This one might give you a better understanding of some of the anatomy that's there. So we're looking at a big muscle in the skull here, and then we're looking at a big muscle on the side of the jaw. What are these things?
Okay, so those are your clencher muscles. And actually there's one more muscle that's hidden that you can see horizontally. Yep, so the big one called the temporalis, that is your temporalis muscle. That's the muscle that helps us close the mouth. That's a clencher. Same thing with the masseter. Those are our real clencher muscles, so that when we grin and bear it, especially during these challenging times, those muscles contract and create a force. And when they contract a lot, the little disc can get squeezed and gets pushed forward.
Okay.
And just put the muscles in spasm. So occasionally you'll see people who, when they clench, the sides of their cheeks kind of pop out like a squirrel holding a nut. And those muscles become like rocks. And if you press on them, those can refer pain to other places and give headaches.
Got it. So that's kind of the couple. There's a bunch of signs and symptoms, but the major ones are headaches, I would assume, right? And some kind of locking and clicking sensation. Is that correct?
And pain in your jaw, and pain sometimes on chewing, and sometimes difficulty yawning. And sometimes you can't open your mouth too wide, or you opened your mouth too wide and now you can't close it again. So there are, yes, things associated, or neck aches.
Oh, neck pain, correct. Yes.
Neck pain.
So let's go. I'm going to share another image of the signs and symptoms. So it'll help us kind of go through some of the common things. So you mentioned head pain or headache.
Mm-hmm.
Is there a common pattern for that associated with TMJ?
Well, the headache, usually patients will say they get a headache here, like a headband headache, or they get pain like in their temples.
Okay.
And when you press those muscles, you feel the spasm in it. When you have them clench, you tell the patients clench, they bulge. And you can feel sometimes like a little, almost feels like a little pea. You feel a trigger point. And sometimes when you touch that trigger point, that'll refer pain to other parts in their body. So for instance, a patient may tell us that they went to their ENT and their ENT said their ears are fine, but they have TMJ.
Yep.
So they come to my office now, and then they're telling me that they feel underwater. They feel like they can't hear as well. And it's just, everything just sounds foggy to them. And when you press the masseter muscle, and there are certain points, and if there's a trigger point, that trigger point shoots pain right into that ear. And that muscle is what's causing that feeling, that underwater. Sometimes it's even causing tinnitus. Tinnitus, take your pick on how you want to pronounce it, which is a ringing in the ear. And when we can release these muscles, it stops. For some it doesn't, but for a lot of times we're finding we can get them to stop.
Great. Now you mentioned when somebody comes to your office for the first time, what is a kind of a common workup for this and diagnostic tests?
Okay, so we do it's about an hour long, sometimes longer clinical exam where I will ask you questions starting from your childhood. I want to know if you've ever had any kind of injury to your head or your neck. For adults, women especially, we'll go back and say, were you a cheerleader? Were you a gymnast? Did you ever, fall on your face? Sometimes it's an accident related case. So we go through the history on that. We go through your medical history. You go through your family history. Then after we ask every doctor you've seen for this situation, then we do a clinical exam. We measure oral opening. We do a muscle exam. We do a joint exam. We do a dental exam. We want to make sure that it's not a dental issue, because sometimes, you're in the forest, you have to be able to see a tree occasionally. And sometimes that tree is a dental pain, not a jaw joint pain. So for that case, we take what's known as a Panorex radiograph. If you ever had braces, it's one that goes around your head, or if you've had your third molars taken out, it's an x-ray that goes around your head, and it shows us all of the gross structures. It'll show us your jaw joints, and it'll show us your teeth. And we're looking to make sure that there isn't dental pathology, or there isn't a gross, like there's not a tumor, that there's not a jaw break. And that helps us have a working diagnosis. And once we have a working diagnosis, then we start working on how to get you feeling better.
Now, you mentioned earlier about the anatomy and the importance of this little disc that's between the bones. So that's the bones of we call the mandible and your skull, correct? So there's a little disc in between there. Can you see that on X-ray, or do you need to do some other tests to see where that's positioned?
Correct. So to see the disc's position, that's an MRI. And usually you can pretty much diagnose without an MRI. When I need an MRI, I need it if some patient comes in with acute pain and they cannot open their mouth more than, say, one finger, maybe two. That's not a normal range. Normal for most people are 3 fingers put in their mouth like this way. I will request an MRI, because in that case, it's usually the discs are too forward and they're acting like a doorstop. So as the mandible is coming down, there's an impediment. And so an MRI will show us that disc is forward or back or wherever that disc is. That's when an MRI will show us. But a lot of times I can diagnose without an MRI. MRI we like to do, especially if we're thinking of a surgical case. Or we want to, or we just can't get the patient better with conservative therapy, and we're kind of going to the next level of figuring out a diagnosis. Then the insurance company allows us to have an MRI then.
Yeah. Yeah. So that's the difficult part. I mean, obviously people, they hear you talking about a disc and they think it's a disc like a meniscus in their knee and they want to get an MRI. And obviously it's something that clinically you can diagnose just by doing the exam.
Correct.
Most of
And
the time.
patients sometimes lead me to it because patients will say, I have clicking, and they
Yep.
just hear clicking. Or they'll say, I have, remember cray paper?
Mhm.
They'll hear a cray paper sound, that kind of crinkly sound that they feel. That one will tell me that the patient usually has arthritis in the joint. And usually you see that on patients older than 25. You don't usually get that on young patients.
Okay.
Then if they'll tell me that they clicked, and then they stop clicking and they can't open their mouth now.
Okay.
That's usually when the disc has slipped forward.
Got it. And so most of the times, you're going to treat that by relieving some of the spasm, and we're gonna talk about some of the treatment options. But is there any other initial things that you might do for the patient after your assessment?
Right. Okay. Yes. So I will sometimes do a spray and stretch technique where I'll use a cold spray if I think that it's just muscle. If I think that it's only muscle, I will use a cold spray and I will massage the muscles in the face. And if I can get the patient to open more, then I know it's probably muscular in origin. If I can't get them open anymore and it feels hard when I try to open them, then I know that it's probably disc and bone related.
Okay. So that's a little bit of a diagnostic technique as well.
Yep. And I've had some interesting cases where I've had to do a diagnostic block because we don't know if it's dental or if it's jaw related. So I'll get a patient numb and see or if it's orofacial pain, which is we have like a neuralgia. And
Mhm.
so I'll try to get an area numb thinking it's a tooth. And when the patient still has the same feeling, then
Mhm.
I know it's not the tooth. Then I know that this is neurologic and I can make the referral to a neurologist.
Got it. Now, do you typically see this on just on one side, or does it happen on both sides of the jaw? What's common?
Patients will tell me it's on one side, but a lot of times when I start palpating, I can palpate pain on both sides. But most patients will say, oh, no, it's really just this side. And then I'll palpate this side and they go, oh, that really hurts. Or when they open their mouth, their jaw will deviate or deflect to one side. And I know that that's where the joint pathology will be, to the side that it's deflecting to. And sometimes they'll tell me it's all of this. And
Yeah.
when they're telling me that every single tooth and their whole face hurts, usually that's a sinus component to it.
Yeah.
So,
Good point, because quite often there you have to do some differential diagnosis and see it's just not the TMJ. There might be some other factors going on, and yeah, and we're gonna talk further about that. So right now, let's take a break, and when we come back, we're going to talk about some of the treatment options available, some of the conservative approaches, and when do you necessarily have to refer this to an oral surgeon. So
okay.
we'll be right back with Dr. Michele Schultz-Robins after this break.
The COVID pandemic has forced arts venues across New Jersey to close their doors. We hope this is just an intermission, but your support is needed now more than ever before. Without it, many may never reopen, impacting countless local businesses and communities. The arts in New Jersey drive $662 million to our state's economy. Recovery depends on you. Learn how you can help at keepjerseyartsalive.org.
Hey, let's check out this park. Oh, wow, that's really cool. To find a great local park or forest near you, go to discovertheforest.org.
There's a shelter pet who wants to meet you. Meet one today. Visit theshelterpetproject.org. Adopt.
Hi, welcome back to You and Your Health. I'm your host, Dr. David Bertone. Our guest today is Dr. Michele Schultz-Robins. Dr. Schultz-Robins is a dentist at Two River Family Dental Center, and she has a specialty in TMJ disorders and oral facial pain. Again, Dr. Schultz-Robins, thank you for joining us. So when we left off, we were talking about some workup and specialty tests. You did want to mention how to rule out that sinus problem versus TMJ.
Right. So what I tell my patients, I have my patients lean over, bend over, put their head between their knees and quickly come up. If their head feels like a bowling ball, then that's usually a sinus. So then we tell the patient to, see an allergist, see their physician, or, take some antihistamines and decongestants and see if that helps to, get rid of the pain.
Great. Okay, so now you diagnose it as a TMJ problem. What are some of the initial treatment options that you do?
Okay, so the first thing we always tell patients is self-care. So with COVID especially, patients are working from home. Their laptops are on their beds. The students are, their schoolrooms are now their bedrooms, and they're bending down and looking down constantly. So we're telling them to get a good workspace. Look directly, notice where your posture is, as we're both sitting up better now. And then it comes, and then it comes to, small bites, no bagels. If you're gonna have a bagel, break it up. No sub sandwiches. For some people, they know them as hoagies. No hoagies, no biting into anything very big. So a soft food diet. You can do ice, you can do heat to the affected joint, whatever makes you feel good. We do recommend some anti-inflammatories and Tylenol. And we also, if patients have a lot of pain, I will put them on a very short course of an oral steroid, and sometimes a muscle relaxant. Because if they're telling me they're waking up and they're just feeling awful and their muscles are killing them, then I'll put them on a muscle relaxant that they take before they go to bed. We also will do injections. We can do sterile saline. I'll do a mix of anesthetic and dexamethasone, which is a steroid, and I'll do Botox. So depending on the indication for the patient, it will depend on what type of injection I'm going to do. Also, I like orthotics, which is, an oral appliance that is made for the problem that we're dealing with. So if a patient, usually we do full coverage. And if a patient is having strictly a disc problem, mostly, I will make something that looks similar to that with a little ramp on it so that it'll bring their jaw forward a little bit. So when they close, the space between their mandible, the condyle, and the skull opens up a little bit. So they're not putting a lot of pressure on that, and that can relieve their pain. And also, I am a big believer in PT. So you are my first place that I send patients to. It's because the patients don't realize how much this is postural. So I need them to relearn posture training and neuromuscular re-education and just how to breathe again.
Yeah, that's all so important. I mean, we get them and they have this bad forward head and they're at the computer all day.
Well, I call it tech head. They've got tech head and tech neck now, because they're all like this. We're all like it. We're all it's awful.
Yep. So when they come to physical therapy, we're assessing their neck, we're looking at their jaw, we're getting the mechanics better, relieving some of the pressure, decreasing some of the muscle spasm, and then you're doing that as well. We forgot to mention some of the causes of this. Now we know that stress is a big one. Let's talk about grinding, because I know that's a very common complaint and cause of TMJ. Can you talk about that a little bit?
So oddly enough, I don't think it's as much grinding as it's clenching. I always tell patients, you're grinning and bearing it. This is all we're doing. We're kind of like doing like this all the time. Because I have plenty of patients who have worn their teeth down to nubs and they're perfectly happy and have no pain. But it's the ones who all of a sudden they've broken a tooth. They cracked a nice healthy tooth. They they just are they're doing this. Before COVID, people would commute and their shoulders when they're driving and they'd be like this. So it's the stress, and it's just we're living in stressful times. And
Yep.
so we're not breathing enough. We're breathing incorrectly. And so there's a lot of stress induced. Also, an accident. You get hit in the back, you get a whiplash injury. That's going to cause jaw issues. You get a direct trauma, a macro trauma, you get hit in the face. That's going to be a problem. You fall. One of the more interesting ones is patients who have had foot surgery.
Hmm.
Yes, and they've been now put on and crutches, or they've been put on one of those little wheelie carts.
Yep.
All of a sudden, everything is thrown off and their jaws start to hurt them, which is just remarkable to see that. And I had a whole bunch before COVID of patients who had foot injuries, were on crutches, and then all of a sudden had jaw issues.
I wonder if that has to do with their stress levels just from an injury.
Well, it's a stress level. And also if you think about the crutch,
Yeah.
I mean, I'm sure, I don't know if you like crutches, but I'm sure a lot of times patients are just handed crutches, but they're not fitted properly.
Yeah, we see that all the time, and we have to adjust them. And
Mhm.
yeah, but I think that you talked about stressing and anxiety. So I would assume that's something else that you would recommend as a treatment, relaxation exercises, mindfulness. These things have become very popular in a lot of things that we treat.
I see patients and even in my chair, they're kind of like this. They're getting in that turtle position. They're getting very, very closed in looking.
Mhm.
And I'm like, okay, let's put your shoulders back. Let's put your tongue to the roof of your mouth, right behind your front teeth. So it's lips together, teeth apart, if you want to do it that way.
Mhm.
And just breathe.
Mhm.
And it's funny, you watch the patients breathe and they look relaxed all of a sudden.
Yep.
I get it. Now my shoulders are down there. And then we start talking and their shoulders come back up again. But for the most part, if I can teach them that, then they're going to be okay.
Yeah.
Also arthritis will do it. All of a sudden I have a demographic of over 75-year-old people, men and women, because they've got arthritis. They're still active. They're on computers and phones all of a sudden, and the arthritis in their jaw and their neck is kicking in, creating a problem. And then they start kind of guarding and they start having pain.
Yeah, we see that as well in the senior population. They're into the iPads now because it's big and it's easy to manipulate. And they start getting a lot of tightness in the anterior neck muscles, which pulls on the jaw, and that starts causing some of those problems. So yeah,
And
I mean, we need to treat those symptoms and prevent some of the things that develop further down the line.
Yep. And sometimes it's just genetics. It's just, this is who you are. And this is kind of, your mother had it, you have it, your grandmother have it. And sometimes it's structural. I wish I had remembered, I have a patient, his condyle, his jaw joint looks like an anvil. He's flattened it out. Instead of it being nice and rounded, it's flat. So he, has been clenching, and he just remodeled it. And he's functioning, and he wears a night guard. And when he wears his night guard, he's good. When he's not wearing his night guard, he'll call me and say, I'm having pain. And I'll say, put your night guard back in.
Yeah. So the night guard, the purpose of that is not only to protect your teeth if you're grinding or clenching, but it provides a little decompression in the jaw. Is that what it's doing?
Exactly. And that's exactly what it does. Because if I can keep you open at this point, I can keep you not squishy up here. And remember, even though this is fibrous, there are blood vessels, and you can squish them and create pain. So you can actually have the synovial fluid gets all inflamed, and you can get a synovitis of your jaw joint.
Yeah.
So that'll help that. Also, if we can start stretching out the muscles a little bit, the muscles will start to relax.
Yeah. And that's one of the techniques we do in physical therapy. So I often will put my hand inside the patient's mouth, and I'm grabbing the mandible, and I'm distracting and opening that joint. So those muscles, just like any other joint, you got to stretch them out and decompress the joint. So when you do it with an appliance, that's something they wear either all day long or at night, correct?
Depending on their symptoms, all day, all night, or just at night. And most patients now will tell me after wearing it and getting used to it, they're like, I can't go to sleep without it.
Yeah.
And they find they're sleeping better because even though they may be still clenching, they are not hurting their teeth, and they're not clenching. The clench isn't as hard because there's something in between now.
Okay. So can I say that most of these problems do get better with the treatment options that you have available?
Most of them do. Yes.
Yeah. Now, if they don't get better, what happens then?
Okay, so now when they're not getting better, that's when we're doing an MRI. That's when I'm referring to the oral surgeon to see, if it's strictly a muscle issue, I can usually get that better. If it has a joint component and the joint component is just not resolving, for some patients it absolutely resolves with appliances and physical therapy, but for some patients they need a surgical intervention. There are a couple types of intervention that a surgeon can do. One is called an arthrocentesis, which is a very mild procedure that's done in the office where they go in and they just kind of flush out the jaw joint. And for some people that's enough and it gives them a good range of motion after. If they need something more, there's arthroscopy, where they will go in and really scrape the tissue, the bad tissue, and get rid of that. And then after that, there are, joint replacements, which we don't really do that much anymore. TMJ surgery has people do it, but we don't do it that often.
Yeah, it's kind of a rare event now.
You have to be really, really bad to have that. So, I don't see that as much, and I don't refer that as much because luckily I'm able to manage my cases. And most of the patients, when they hear surgery, they really want to try conservative therapy beforehand.
Yeah, and years ago, we thought that, so the disc is kind of forward in the condyle, and we thought that if you surgically put it back, that it was going to be better. And now we realize it really doesn't make that much of a difference.
No, there used to be a surgery that they pinned it back. And what they had found, I think by the time the patient actually left the operatory, it was back to where it was.
Yeah. It didn't work. So one of the other big things that you work with is this oral facial pain. Can you just talk a few minutes about what that is?
Sure. So oral facial pain is not TMD. It's patients who have trigeminal neuralgias or some sort of neuralgias. And those patients usually get, they're managed more medically. They're managed with tricyclic antidepressants. They're managed with anti-seizure medication. They're managed on a medical basis. Those are patients who just, I work closely with a few neurologists, and those patients, those are the oral facial pain patients. Those are a little trickier, but those are really interesting also.
Yeah. Is there a common presentation of somebody like that?
The presentation is usually unilateral. And it is a pain that doesn't go away, and it usually feels electric. So if a patient has an electric type of pain and it's not dental, then it's usually neurologic, because we have this one nerve back here. It's called the trigeminal nerve, and it has 3 branches. One branch goes here, one branch goes here, and one branch goes up to our eye, which is why when you have any dental work on the bottom, usually for the bottom teeth, the main nerve is all the way in the back. So you ever noticed you get very numb at the dentist if you have anything on the bottom? On the top, the nerve kind of runs into each tooth. So you can block those, you can infiltrate them at the tooth site. And when there is some sort of misfiring, patients will usually tell me, it's like, all of a sudden they have a toothache, then it goes away, and it's spontaneous. And it just feels like nothing they've ever had before. And in those cases, I usually send them off to the neurologist, and we work them up for a trigeminal neuralgia. They go on a course of medication. But the one case I told you about earlier in the first segment, where first half, where I did a diagnostic block because the patient was referred and said, I think it's his tooth. And I'm like, I don't know. It doesn't sound like a tooth. So I did a block, and I said, do you feel your tooth? He says, no, I don't feel my tooth, but I absolutely still feel my pain. I said, okay, that's easy. You're going to go to the neurologist now.
Great. Well, thank you so much for joining us today and talking about TMJ and oral facial pain. I really appreciate you giving up the time. And until next time on You and Your Health, I'm your host, Dr. David Bertone.